Hello everyone, this is Dr. Ahmed Abdul Wahab and this is Highlights in Radiology. بالبداية أريد أنوه أن هاي الحلقة برعاية مركز القلعة للاشعة التشخيصية، وهو مركز متكامل يحتوي على كل أنواع فحوصات الأشعة من الرنين المغناطيسي والمفراس الحلزوني والسونار والدوبلر الملون والأشعة العادية والملونة وفحوص الثدي الماموغرام وفحص هشاشة العظام كذلك، بالإضافة إلى مختبر مجهز بأحدث الأجهزة وكافة الفحوصات المختبرية. بالإضافة إلى ذلك يحتوي المركز على مركز لمعالجة الأورام السرطانية ومركز لعلاج الأمراض العظام والكسور، بالإضافة إلى مركز للعلاج الطبيعي مجهز بأحدث الأجهزة. مركز القلعة للاشعة التشخيصية في اربيل، راح تلاقون كل المعلومات موجودة في وصف الفيديو. خلونا نبلش. Okay, so today we're going to talk about the cystic lung pattern on high resolution CT scan. And when we say cystic, we mean air cyst, not like soft or fluid filled cyst or soft tissue density cyst. So air cyst lung pattern on HRCT. If you see this appearance, what it could be? First of all, the first differential diagnosis, we'll divide them into common causes and uncommon causes. The first of the common causes is bronchiectasis. Bronchiectasis is one of the commonest causes of cystic lung appearance on HRCT. And the bronchiectasis, as all of you know, there are different types of bronchiectasis. First of all, this is the normal appearance of the lung bronchi and bronchioles, and when they got dilated, it can be in a soft, smooth way of dilated bronchi and bronchioles. This is what we call cylindrical bronchiectasis. If it is like that, it's like a varicose vein, we call it varicose bronchiectasis. And if it is multiloculated, we call it cystic bronchiectasis. So one of the signs that we see in the chest X-ray and the chest CT scan is what's called tram track cystic lesions. Tram track, first of all, in this chest X-ray, we can see there are multiple innumerable cysts involving the right lung. Some of them contain even some air fluid levels. Okay, so this is what we call cystic bronchiectasis. And in the CT scan, the HRCT, it's even much more obvious. This is what we call the honeycombing appearance. You can see it's like a honeycomb with multiple air-filled cystic spaces. And in this example, it can be less prominent, but also so easy to see. There are multiple cysts involving the right lung. They are air-filled cysts, and if you look at the wall is perceptible. You can see the wall of this cyst, confirming it's bronchi. It's just dilated bronchi. In this appearance, it's very easy to appreciate the tram track cystic lesions. You can see the bronchi are dilated just like a tram track with cysts or air-filled cysts, sometimes contain some air fluid level due to mucus in the bronchi, and this is tram track sign of cystic lesions. And also in the X-ray you can appreciate the tram track sign here and there with air-filled cyst, confirming it's just a bronchiectasis. So the second common reason of cystic air lesion, it's air or cystic appearance of the lung, is what we call bronchiolitis obliterans, also known as obliterative bronchiolitis. It's just due to inflammation of the mucosa of the bronchi. This will result in narrowing of the lumen and obliteration of the bronchioles, and that's why we call it bronchiolitis obliterans. So what will happen is that there is a peripheral attenuation of the vessels, resulting in hyperinflation. However, when you do an HRCT, it will show mosaic pattern of perfusion. Areas are perfused well, other areas are perfused bad, and you will not see cystic pattern on HRCT. You will see it only in the X-ray, chest X-ray. You'll see the cystic pattern. You do the CT scan and there is nothing there. So this is a possibility of bronchiolitis obliterans. What are the causes of bronchiolitis obliterans? How can a person get that? First, you have idiopathic or cryptogenic or post-infectious, sometimes noxious fume inhalation, neuroendocrine hyperplasia, and in post-transplant patients. So, for example, let's see this. If you look carefully here, you can see some air trapping here and there. It looks like faint, small cysts. So let's do a CT scan for the patient. You can see in the normal inspiratory HRCT, high resolution CT, there is nothing there. It's normally aerated lung. However, if you go and do an expiratory CT, and then obviously there are areas of air trapping resulting in this mosaic pattern of attenuation, and this is confirming it possibly the possibility of bronchiolitis obliterans. Other examples, you can see the areas of air trapping here and there, giving the appearance of cystic air cysts in the lung, but they are not air cysts, just trapped air. Another example, you can see here, it looks like some kind of cystic appearances here and there, but they are not real cysts, they are just trapped air due to bronchiolitis obliterans. The other common cause, possibly the commonest cause of them all, is emphysema. And I will not talk about the definition of emphysema, just the types of emphysema includes the centrilobular, as in this case. You can see all the lobules have small air-filled cysts within them. This is what we call centrilobular. The other type is paraseptal. You can see along the peripheral parts of the lung, the septal regions, also the panacinar. As you see here, it's completely destroyed lung. All the acini is involved. It's panacinar. Everything is destroyed or widened and air-filled. And the last and the most, the biggest type is the bullous. You can see it's a bullous emphysema or bullous nematocele, let's say, bullous air-filled cyst here and there, and sometimes even can lead to very severe complication, as in this case. You can see it's a big bullous. This is not a pneumothorax, it's just an air cyst. You can see the effect on the adjacent lung. It's causing a mass effect on the lung, confirming it's an air cyst. Okay, the other cause, it's interstitial fibrosis. Interstitial fibrosis usually in diseases that involve the lung and cause diffuse idiopathic pulmonary fibrosis, like in scleroderma or rheumatoid lung disease. And this is what we call the end-stage honeycomb pattern. For example, you can see here, this is a very nicely demonstrated honeycomb pattern of diffuse idiopathic pulmonary fibrosis. More clearly seen here, the peripheral distribution. Also, there should be an apico-basal gradient. We will not talk about that, but you can obviously see the honeycomb pattern of idiopathic pulmonary fibrosis causing the cystic air lesions appearance. In the X-ray, it appears as diffuse cysts here and there, everywhere, multiple cysts. Okay, and you can see also here in this HRCT the peripheral distribution, and it's less prominent in the upper part of the lung, and it's more prominent in the basal part of the lung. This is what we call an apico-basal gradient of honeycombing of idiopathic pulmonary fibrosis. Of course, honeycomb is a sign that can be seen in bronchiectasis also. In fact, it's well known for bronchiectasis rather than the pulmonary fibrosis, but it's also seen in idiopathic pulmonary fibrosis. And this case, here you can see there are diffuse air-filled cysts, less prominent in the upper part of the lung, more prominent in the basal part of the lung, and this is what we call apico-basal gradient, very characteristic of idiopathic pulmonary fibrosis. Now, the other cause is just a nematocele. As its name says, nemato means air, cele means cyst. So it's air-filled cyst, that's it, just a cyst filled with air. It can be traumatic, can be post-infectious, especially in pneumocystis carinii, previously now it's known as pneumocystis jirovecii, or staph infection. So it's staph infection is relatively much more common. The PCP infection is mainly in HIV or AIDS patients. So you can see in children, for example, this a very well-defined cyst here and there, and it's filled with air, confirming it's a nematocele. It's an air-filled cyst. It can be very large, and if it ruptures, it can cause pneumothorax. So you can see this is the big cyst, and it's ruptured and causing collapsed lung and pneumothorax, and even it causing mediastinal shift to the right side, which means tension pneumothorax. So this is an emergency. Another example, in the CT scan, you can see it's a very large cyst. In fact, be careful, you might mistake it for a pneumothorax. If you continue with the images, you can see its effect on the adjacent lung. The pneumothorax will not cause this appearance. Pneumothorax will be something like that, but more peripheral here. So it's not a pneumothorax, it's an air cyst, and multiple small cysts also seen in the other lung, and this was a case of PCP infection. The uncommon causes of air cysts, first of all, we will talk about the two most known conditions. The first one is the Langerhans cell histiocytosis, in which we will see cystic lung lesions with nodules. It involves mainly mid and upper lung zones. And in fact, these are eosinophilic granulomas. These are e.g. eosinophilic granuloma. You can see there are innumerable cysts involving all lungs, and it's more prominent in the mid and upper lung zone, while idiopathic pulmonary fibrosis, even in most types of bronchiectasis, it's in the mid and lower zone, while here it's in the mid and upper lung zone. So you can obviously see the difference here. It can be more prominent, more severe, like in this case. You can see it's more thick, and the nodules probably more prominent here and there. Also, it can be more prominent and more obvious than this case, as in this condition. You can see here it's multiple innumerable nodules with air cysts confirmed, which is a very characteristic of severe Langerhans cell histiocytosis. Also in the X-ray, it appears like that. You can see multiple air-filled cysts here and there, okay, due to Langerhans cell histiocytosis. Another example of chest X-ray of Langerhans cell histiocytosis, you can see the diffuse involvement of both lungs with these cystic lesions, confirming it's a Langerhans cell histiocytosis. The final condition that causes the cystic appearance is the pulmonary lymphangiomyomatosis, or what we call LAM. Okay, in LAM there are diffuse cystic lesions involving both lungs from up to down. Everything in the lung is cystic. However, keep in mind, in LAM patients, of course, LAM is a part of the tuberous sclerosis. So it's a part of tuberous sclerosis syndrome. So most of the patients, they have tuberous sclerosis. And keep in mind, please don't forget that when you are writing your report or your differential diagnosis, LAM patients are always female, okay? Always female. You never write LAM lymphangiomyomatosis on a male patient. And this what the CT scan looks like. You can see the whole lungs are involved with cystic lesions. You can see this is probably less severe case. However, the distribution of air cysts is very prominent, and you can see again another example, multiple variable size cysts involving both lungs, and it's always female, okay? And diffuse lung involvement with multiple air cysts, you can see on this CT scan in a case of lymphangiomyomatosis. Another example of this chest X-ray of a female patient showing the diffuse cysts all over both lungs here and there, in this case with known tuberous sclerosis and pulmonary lymphangiomyomatosis. So this was our presentation for today. I hope you find it well and informative, and keep in mind we have to do the 10K by the end of November, and the 10,000 subscribers, so that you can get your brain CT scan mini series explaining all the differences and the requirements to do a proper CT scan and what to look for from from scratch for beginners. Keep watching us. See you next week, next Friday at 5 p.m. This was Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology. Bye.